Good afternoon, everyone. As you all know, we have gathered here today for this important CME regarding the developmental issues in children, prevention and early identification. So, over the next 2 hours, we'll be discussing something about the developmental issues we see in children and what can be done to prevent them or identify them early. Okay, so moving to the first part of the talk today, that is regarding the perinatal and early neonatal interventions to improve the developmental outcomes in children. Okay, that the neonatal care over the last few decades has advanced a lot. So this is actually the first picture of incubators, and this is from way back in 1934. So this is actually originally how the incubators were. You can see the babies who are being cared for inside the incubator. Okay, so these were the original incubators, and as I told you, this is from 1934. Cut to 2026, where we have more advanced incubators, ventilators, TP's device, infusion pumps, TPN, everything, hi-fi things are there, including inhaled nitric oxide, bedside echo, and all. So as you can see from these two pictures, that the neonatal care has advanced a lot over the last few decades, or maybe over the last century. So at the same time, the yardstick to measure the quality of care has also changed from survival. So at one point, when we were talking about the conventional neonatal care, the priority was to ensure survival. Uh, Now the priority is to ensure intact neurological survival. Okay, so we are in the era where we don't just target survival of a newborn. We want the child to be neurologically healthy and to be contributing effectively to the society in future. I will start with the interventions which could be done in the perinatal and the early neonatal period to improve the neurological outcome. So I'll be talking about 14 interventions. Since it is a bigger talk, I will go a little bit fast. And mind you, my job today is not to discuss all the evidence in detail, but the point is that we should know what all interventions can be done and a little bit about what is the evidence regarding that. Okay, so coming to the first part of the talk, that is about antenatal steroids. Now we all know that steroids, they help to improve the lung maturity in the fetus. Okay, but nowadays we are not talking only about the lung maturity. Even the steroids, they have got an impact for neuroprotection. When I talk about neuroprotection, what do the steroids actually do is they increase the stability of the germinal matrix and decrease the permeability of the blood vessels. Also, they help to reduce the chances of IVH in a child by close to 31%. Okay, so as we all know that IVH is one of the major neurological morbidities in the premature babies. So giving antenatal steroids and completing the course of antenatal steroids, it helps to decrease the chances of IVH and it helps to stabilize the germinal matrix. But it is not that steroids are beneficial always. Okay, this use of steroids in antenatal as well as in the postnatal scenarios, it is always a double-edged sword. There are certain drawbacks of using steroids also, especially when you are using repeated courses of steroids. Then in that case, it has been seen that repeated courses of steroids would lead to decreased neuronal proliferation and differentiation, and also it will lead to decreased cognition and impaired neurodevelopmental outcomes. Okay. Uh, so that is why most of the bodies they recommend giving one extra course. So if you are suspecting a premature delivery, you can complete one course of steroids. If there are 7 days or more that have passed, you can go for a second course, but not beyond two courses. Okay, because repeated courses they tend to worsen the neurological outcome. Remember is that the steroids, when given, they should be given either as a single course, or if at all they need be, you can go for one extra course of steroids. If you use more courses of steroids beyond one extra course, it is associated with impaired neurodevelopmental outcome. Second is that many a times in our setup also we see that if a mother comes to our antenatal ward at say 35 weeks of gestation, the obstetricians all over the country, I feel they have a tendency to give steroids for the benefit of doubt. They are not sure that whether the child is 34 week or 35 week, or even if the child is 35, 36 weeks of gestation, the OGs they have a tendency to give one shot of steroid and then deliver. Now, what is the problem is that the late preterm babies and the term neonates in them, when you study the neurological outcome after giving a course of steroids and then delivering, it has been found that actually exposure to antenatal steroids increases the risk of mental disorders in the cohort with a hazard ratio of 1.13, which means that the late preterm babies and the early term babies who have received a course of steroids, they are expected to have 13% higher chances of mental morbidity if they are receiving it in the late preterm or early term gestation. Okay. Second is that if suppose you are strongly suspecting that, okay, the mother is about to deliver in say next 24 to 48 hours prematurely, but somehow you completed the steroids and mother does not deliver now, and then she continues the pregnancy and delivers at term gestation. In that case also, they had a systematic review where term or late preterm births after exposure to early antenatal steroids, they have studied the neurological outcome, and in that case also there is increased risk of admission to the NICU, increased risk of intubation, decreased head circumference, and increased chances of neurodevelopmental or behavioral disorders. Okay, so all these data, what they suggest that the use of steroids has to be cautious. Okay, there was one more study which was published in 2024 in the American Academy of Pediatrics journal. In this study, surprisingly, they have concluded that there is no adverse neurological outcome till the age of 6 years when steroid was given in the late preterm babies. Okay, so looking at the overall evidence, there is still a lot of confusion whether to give steroids in the late preterm group or not to give, and based on that, actually. So because there's a lot of heterogeneity in the studies available in the type of steroid that has been used. So heterogeneity in the data which is available, and the evidence is actually conflicting. And even if there is benefit which has been shown in some of the studies, the benefit is marginal. Okay, so when you are using steroids for very premature babies or for your moderate preterm babies, there is definitely a survival benefit. But when you are using it for late preterm or early term babies, the chances of benefit or the evidence of benefit is marginal, and rather there is actually a chance that you may actually be causing more neurological damage to the child. So various bodies, they have got different recommendations. If you look at the ACOG or RCOG guidelines in Europe, they tend to have inclination towards giving steroids in the late preterm babies. But if I talk about the Indian guidelines, so this is the official guideline which was published in 2014 by the Government of India, Ministry of Health and Family Welfare, and the Indian guidelines are strictly against giving steroids in the late preterm group. So what the Indian guidelines say is that you should give steroids only between 24 to 34 weeks of gestation. Beyond 34 weeks of gestation, since the benefits are questionable and there is a potential for harm, steroids should definitely not be used. So this is one thing which we should always emphasize to our obstetric colleagues also, that beyond 34 weeks, since there is not much evidence of benefit, it is better to avoid giving steroids at this point of time. Then coming to the second intervention, that is antenatal magnesium sulfate. Now, a sad part is that the steroids have gained their name. Everyone in the obstetric side, they know that steroids have to be given to improve the outcome or to improve the lung maturity of the fetus. Unfortunately, there are not many obstetricians who still know that magnesium sulfate has got a very strong role to improve the neurological outcome in the child. Okay, how does it help is that it actually acts as the NMDA receptor antagonist, and it decreases the excitatory calcium release. It decreases the extracellular glucose levels, thereby reducing excitotoxicity. It limits the calcium influx, and also it has got anti-inflammatory properties. So because of all these actions, what magnesium sulfate actually does is that it helps to decrease the risk of cerebral palsy. So now this is the data from meta-analysis. And if you look at this circled portion carefully, so all the studies, they have a very strong evidence favoring magnesium sulfate. If you see in all these studies which I have shown, the relative risk is around 0.68, 0.69, 0.7. So what do these numbers indicate? That if you use magnesium sulfate, there is a chance, 32% chance, that the child will have less cerebral palsy with the use of magnesium sulfate in the antenatal period or in the perinatal period. Okay, so that is why magnesium sulfate has to be given. If you look at this last figure also, it shows the number needed to treat. So if I tell you the number needed to treat of 63, which means what? For every 63 premature babies, if you give magnesium sulfate in the antenatal period, you are preventing one cerebral palsy. Now, magnesium sulfate is a very cheap drug. It is not very costly, not something to obtain with difficulty. So giving one magnesium sulfate, if you give magnesium sulfate to 63 mothers, and if you are preventing one cerebral palsy, actually it is cost effective. Okay, and it has got not many side effects for the mother or the baby. So that is why magnesium sulfate in the antenatal period has to be given. Again, this is one thing which has to be emphasized. There are not many obstetricians who are still following it, but there is a very strong evidence favoring magnesium sulfate in the antenatal period. So what do the guidelines recommend? So the FIGO, that is the International Federation of Obstetrics and Gynecology, and even the ACOG, they have given very strong recommendation that if you are expecting a delivery before 30 weeks of gestation, magnesium sulfate has to be given. There is a strong recommendation, and between 32 to 34 weeks, or maybe less than 32 to 34 weeks, it should be considered. Okay, so less than 30 weeks, it is definitely mandatorily to be given. Less than 32 to 34 weeks, I mean between 30 to 34 weeks, they can consider the use of magnesium sulfate. Then coming to the third intervention, which is very interesting one. If you read it, it is do not deliver the child electively before 39 completed weeks of gestation. Okay. Now, what happens is आजकल ना बहुत एक ट्रेंड चला है कि every mother wants painless pregnancy, है ना? No one wants to go for a normal labor. Everyone wants, ये होता है. If you go to bigger cities, what happens? Mother आएगी 37 weeks पे obstetrician को बोलेगी I want to do a CS, and no one wants to take the pain of normal delivery. ठीक है? And obstetricians are also very happy because they are earning more. They have to do less of monitoring. If the mother goes in for normal labor and delivers the child vaginally, तब तो obstetrician को भी headache है. रात को 2 बजे delivery होगी, 5 बजे होगी, किसी को नहीं पता. इलेक्टिव सीएस प्लान करके दे विल टेक इट. ठीक है, तो प्रॉब्लम कहाँ है? देयर इज एन एपिडेमिक नाउअडेज दैट majority of the deliveries elective LSCS they are happening between 37 to 39 weeks of gestation. ठीक है, प्रॉब्लम कहाँ है? No one understands that 37 weeks is the cutoff for lung maturity. It is not the cutoff for brain maturity. Your neurodevelopment of the fetus or the brain maturation of the fetus is going on till the 39 weeks of gestation. So it is only at 39 weeks completed that your fetus is ready to come out. Okay, if you deliver the child at 37 weeks, and हम लोग कई हमारे यूनिट में ही all the residents, if the child is delivered at 37 weeks, they will write full term. No, the child is not full term. ठीक है, पहले तो हमको उसको नॉर्मल बनाना छोड़ना होगा. Second is you have to force your obstetric colleagues also that do not bring the child out at 37 weeks. Okay, you follow the nature's rule. 40 weeks is the ideal thing. At least you wait till 39 weeks if there is no urgency. Okay, let us see the evidence for this. So this is one study where they have taken the data of 7 years from a center in Western country, and what they have found is that close to 50% of the babies were born between 37 to 39 weeks of gestation. Okay, unfortunately, I tried to search Indian studies, but there are not many Indian studies on this topic available. But I am pretty sure that in metropolitan cities, the number would be much higher. Okay, because nowadays everyone wants to not take chances with the pregnancy, and that is why majority of the women and the obstetricians, they want to deliver the child by 37 weeks. Okay, but what is the problem? So see, if you can see in this figure, between 26 to 40 weeks of gestation, your synapses are getting formed. There is neuronal pruning, that is apoptosis. Synapses, they get reorganized and myelination is taking place. Okay, now what is nature's rule? That up to 40 weeks it has to happen in utero. Okay, if you deliver the child at 37 weeks, you are not allowing that synaptic organization to happen in utero. बाहर आने के बाद में there are a lot of disturbances the child has to go through. Okay, I mean the in utero environment is actually the ideal environment for the child to develop all these synapses and to have the initial myelination and synaptical pruning. So there are n number of studies which have been done on this topic, that if you deliver the baby at term as compared to delivering a child at 37 weeks. Okay, so these are all the studies which have been done on this topic, and what they collectively say that neurocognitive scores for babies who are born after 39 weeks of gestation are superior to babies who are born at 37 to 38 weeks of gestation. Okay, so that is why always we should try to prolong the pregnancy till 39 weeks. Okay, it happens many times that because the mother wants to bring the baby out and the obstetrician is also happy to bring the baby out, they electively plan a CS at 36, 37 weeks and they bring the baby out. Okay, even if the child may not require NICU admission, not require ICU support or anything, but still you are that 2 weeks of extra stay in utero will help to improve the neurocognitive outcome of the child. Okay, then coming to the fourth intervention, that is delayed cord clamping. So all of us know that delayed cord clamping is now a recommendation. It is very well a recommendation given by almost all the bodies. Now, what is so fascinating about delayed cord clamping? I mean, see, let us agree one thing, that all of us, the entire generation who is sitting here, none of us have gone through delayed cord clamping. जब हम लोग पैदा हुए थे, हम लोग early cord clamping वाले हैं, ठीक है? So why it is important? Why the delayed cord clamping? All of a sudden in the last 10 years, what has happened? बच्चे तो जब से अर्थ शुरू हुई तब से हो रहे हैं, ठीक है? अब क्या हो गया लास्ट 10 साल पहले कि अचानक से हर कोई डिलेड कॉर्ड क्लैंपिंग कह रहा है, ठीक है? सो देयर हैव बीन एन नंबर ऑफ स्टडीज, देयर आर lots and lots of meta-analysis, lots and lots of RCTs which have been done. If you go and search the internet, it was not possible to include all of them, but a few recent ones which are available I have tried to include here. So all these studies collectively, what they conclude is that if you do delayed cord clamping for a term baby, so for a term baby, if you go for delayed cord clamping, what happens is at the time of birth, that extra blood which is there in the placenta, and if you are allowing that blood to come to the baby, you are actually increasing the baby's own hemoglobin content. There is better cardiovascular stability, and over a period of time, it is associated with improved motor function, spatial visual function, and more sensory processing and lesser iron deficiency. Now, in a country like India, majority of our babies in the first year of life, they have some physiological iron deficiency. That to some extent can be prevented if you go for delayed cord clamping. And why is it important? Even more, not that all the babies who are iron deficient will need blood transfusion, but a very important thing to remember is that the iron is the most important component for myelin formation. Okay. The most important micronutrient which you require for the formation of your myelin sheath is iron. So if you have extra iron in the first year of life, if you allow this delayed cord clamping, and if you allow this extra iron to get accumulated, you are actually improving the myelination chances. And so that is what it has been shown in all the studies, that there is an increased myelin content in the early developing brain if you allow these children to go for delayed cord clamping. Okay, so this is for term babies. So definitely for all the term babies, delayed cord clamping has to be done. Even more important it is for premature babies, because for premature babies it has got a survival benefit. Okay, अगर आप term baby में delayed cord clamping नहीं करोगे तो maybe you are decreasing his or her IQ by few points. If you are not doing delayed cord clamping in a premature baby, you are decreasing the chances of survival directly. Okay, so it has got a survival benefit. It has got lesser chances of intraventricular bleed, lesser chances of NEC, though the evidence is not very strong, and there is decreased need for blood transfusions inside the NIC. So definitely delayed cord clamping has to be done. Now, all these interventions mostly to be done in the obstetric side, and they are very easy to do. Okay, then coming to something which should be done in the delivery room and in the NICU. So the fifth intervention is prevention of intraventricular bleed. Okay, so one of the major morbidities which we see in our babies in NICU is intraventricular hemorrhage. Okay, and why are we so much concerned about it is that if you see in this figure, the chances of neurodevelopmental impairment after a child having germinal matrix hemorrhage, there is a 15% chance if it is grade 1 IVH, 25% if it is grade 2 IVH, grade 3 and grade above, I mean more than grade 3, they are associated with almost 50 to 75% chance that the child will have some or the other form of neurological impairment. Okay, and mind you, this is an old study from a Western country. If you talk about the data from India, I am definitely sure that the numbers would be even worse. So what are the problems these children have? So they usually have a significantly lower IQ. They have motor and cognitive impairment. They even a mild IVH. So sometimes we see a lot of babies who have a grade 1 IVH which over a period of time resolves spontaneously. We don't do any change in the treatment for these babies. But even a milder IVH is associated with motor or cognitive delay, hearing impairment, visual impairment, and more chances of CP as compared to a child without IVH. Now, we know that IVH is a problem. What can be done for it? So there are a lot of preventive strategies available. So to understand, to prevent IVH, we need to understand in detail about the physiology as to why it happens. Unfortunately, for the want of time, it is not possible to cover the topic in detail, but these are some interventions which can be done. to in our NICU and in the delivery room that we should avoid hemodynamic fluctuations. So to aggressive use of inotropes or not using inotropes when it is actually indicated, both these scenarios will cause a lot of fluctuations in BP and cause IVH. Head positioning, avoiding hypercarbia or hypocarbia, gentle ventilation, avoiding suctioning, minimally invasive surfactant administration. That is why your LISA or MIST is the modality of choice to give surfactant in ELBW babies, because it helps to decrease the chances of IVH. Also, minimal handling, gentle ventilation, avoid rapid fluid infusions. So that is why we prefer to give all the antibiotics and this thing by infusion. Avoid rapid blood withdrawal, leg tilting, maintain normothermia, minimize stress and pain, and minimize light and noise. So all these interventions, when done together, they help to decrease the chances of IVH. There have been many studies which have used this IVH prevention bundle, and most of them, they have shown that it helps in decreasing the chances of intraventricular hemorrhage by close to 50%. Of course, the results may be different in different units. Coming to the sixth intervention, that is reducing perinatal hypoxia or asphyxia induced brain damage. So I mean, we see a lot of cases of birth asphyxia day in, day out. Based on the area of brain which is involved in birth asphyxia, there may be different outcomes. I'm not going into the details of this slide for the want of time, but all of us know that birth asphyxia is associated with poor neurodevelopmental outcome. So what can we do about it? So one intervention which is definitely useful in decreasing the chances of neurological impairment after a child having birth asphyxia is therapeutic hypothermia. Okay, how it helps is that whenever there is a hypoxia or asphyxia insult, there is initially a phase of primary energy failure. So in this primary energy failure, there is damage to the neurons because of less oxygen and less ATP. After that phase of primary energy failure, there is a phase of latent phase that is between 0 to 6 hours. Okay, so between 0 to 6 hours of birth of a child, you have that latent phase जहां पे अगर आपने therapeutic hypothermia start कर दिया, तो you are actually slowing down the metabolism of the brain, and you are sorry. So you are slowing down the metabolism of the brain, and you are actually preventing the secondary energy failure which will then ensue. ठीक है, तो जब भी किसी बच्चे को birth asphyxia होता है, initially there is a primary energy failure which is happening at the time of insult. अगर birth asphyxia अभी हुआ है, so in utero phase में ही उसको primary energy failure start हो गया होगा. Then between birth to first 6 hours of life, there is a latent period. That latent period is actually the window of opportunity we have to pick up the child and start therapeutic hypothermia. If we start therapeutic hypothermia in this latent period, we are actually preventing the brain from going to the stage of secondary energy failure. So secondary energy failure is the one where you see a lot of free radical mediated injury, lot of inflammation to the brain, and majority of the long-term consequences of perinatal asphyxia, they are because of this secondary energy failure. Okay, so that is why therapeutic hypothermia has to be done. So this is how it helps. It actually stabilizes the mitochondria. It decreases the apoptosis and necrosis of the neurons. It decreases seizures, decreases cytotoxic edema, decreases the inflammation, and it improves the neurological function overall. So there was initially a study way back in, I think, 2021, which showed that if you do therapeutic hypothermia in developing countries like India, the mortality was on the higher side. Okay, but subsequently, there have been quite a few studies in developing countries other than India, in the African countries and all, where they have shown that therapeutic hypothermia actually decreases the mortality and decreases the chances of neurodevelopmental impairment. And so definitely it is the standard of care, but the point to remember is that you cannot start hypothermia for any baby and every baby. There are certain criteria which have to be fulfilled, and only if a child is fitting into those criteria, and if you follow a protocolized approach for cooling the baby, you will save the. Then coming to the seventh intervention, that is preventing hyperoxia in the neonatal period. Now again, this is very important. All pediatric residents, all of us as pediatricians and neonatologists, tend to miss this out. Okay, so preventing hyperoxia in the early neonatal period. What happens is, if there is hyperoxia in the early neonatal period, there is increased oxidative stress, more free radical production, increased inflammatory cytokines, and vascular remodeling. All this is associated with more of inflammatory diseases like BPD, that is bronchopulmonary dysplasia, and also encephalopathy of prematurity in the neonatal period, and it will lead to poor long-term neurological outcomes. Okay, so there is something called the lung-brain axis. देयर इज समथिंग लाइक द गट ब्रेन एक्सिस, ठीक है। तो होता क्या है कि जो भी इंफ्लेमेटरी साइटोकाइंस लंग में प्रोड्यूस होंगे थ्रू दी सर्कुलेशन, थ्रू दी ब्लड सप्लाई, इट विल गो टू दी ब्रेन, और वहां पे भी वो इन्फ्लेमेशन क्रिएट करेंगे, ठीक है। So that is why if you read your NRP protocol, you should always use blended oxygen. That is why always make it a point. Do not use 100% oxygen for resuscitating babies in the delivery room. Okay, because if you do not use this blended oxygen, you are causing hyperoxia. ठीक है, हम लोग खुश हो जाते हैं saturation 99 देख के, but you do not need that 99% saturation in the delivery room. Okay, so use of blended oxygen. जो एनआरपी, दिस टेबल इज टेकन फ्रॉम एनआरपी गाइडलाइंस, ठीक है। सो एट 2 minutes यू शुड टारगेट एन एसपीओ ऑफ 65 to 70, दैट इज इट। यू शुड नॉट वरी कि अरे सैचुरेशन 60 आ रहा है, O2 चालू करो, 100% ऑक्सीजन दो, नहीं, ठीक है। सो NRP has been very categorical in telling that if you have a baby more than 35 weeks of gestation, you start resuscitation with 21% oxygen. If it is between 32 to 34 weeks, you start at 21 to 30%. And if it is less than 32 weeks of gestation, you start at 30%, more than 30% oxygen. So this has to be followed as it is. और इसके लिए ही हमने delivery room में blender रखा है, but that blender has to be used. Okay, double underline. Next is अवॉइड अग्रेसिव वेंटिलेशन, ठीक है। फिर हम क्या करते हैं, हाइपर वेंटिलेट करते हैं बच्चे को। वी आर यूजिंग एक्सेसिव प्रेशर्स, एक्सेसिव ऑक्सीजन, ठीक है। एंड व्हाट ऑल दैट विल डू इज इट विल कॉज हाइपोकार्बिया, इट विल कॉज अ CO2 वॉश आउट, ठीक है। नाउ इफ यू सी दिस ग्राफ, देयर इज एन इनवर्स. So there is a relationship between the CO2 levels and the cerebral blood flow, ठीक है। तो जैसे ही आपका CO2 levels come down होंगे, so when you hyperventilate the child, you are actually decreasing the CO2 levels. जब CO2 levels कम होंगे तो आपका cerebral blood flow भी कम हो जाए, ठीक है। And these fluctuations in the cerebral blood flow, they are not good for a premature child, ठीक है। These will again lead to increased chances of IVH and also periventricular leukomalacia, ठीक है। So aggressive ventilation will in babies with RDS, and after that होता क्या है कि RDS lungs are stiff lungs, but once you give surfactant the compliance improves drastically. तो हम surfactant दे देते हैं वहां तक, ठीक है, but उसके बाद हम प्रेशर्स कम नहीं करते हैं। फिर अगले दिन न्यूमोथोरैक्स होता है, वो तो अलग बात है, बट उससे पहले यू आर कॉजिंग CO2 वॉशआउट एंड डैमेज टू द ब्रेन, ठीक है। सो इट विल लीड टू cerebral vasoconstriction, decreased cerebral blood flow to the critical areas of the developing brain. It will disrupt the blood-brain barrier, pontocerebellar necrosis. Ultimately, it will lead to IVH, PVL, and developmental and cognitive deficits. Okay? So you have to be gentle in your ventilation. Always, if you are ventilating a child, have the habit of looking at the CO2 levels. Okay, you should never allow hypocarbia. You still can accept some degree of hypercarbia. अगर CO2 थोड़ा बढ़ा हुआ होगा तो it is fine, but it should never go to the range of hypocarbia. Then next is avoid the use of steroids in the ICU, है ना? So postnatal steroids is always detrimental. That is one thing which has to be clear, ठीक है। So there have been a lot of meta-analysis which have been done. So this was the meta-analysis जहाँ पे they have studied the early use of systemic postnatal steroids at less than 7 days. This was the meta-analysis where they studied between 7 to 14 days, and then they subsequently studied use of steroids in the NICU beyond 7 days of life. So actually, the evidence is not very clear. There is difference in the type of steroid, the duration of steroid, and the dose of steroid which has been used in different studies. So we definitely need more studies. But since we do not have strong evidence at this point, what we know clearly is that early use of steroids inside the NICU, ठीक है। कई बार ऐसा होता है कि हम लोग बहुत अग्रेसिव होते हैं, सेकंड थर्ड डे पे ही डेक्सामेथासोन चालू कर देते हैं एक्सट्यूबेशन प्लान करने के लिए। So that should not be used, ठीक है। So early use of steroid is always associated with more risk of CP, more GI perforation, and there is a trend towards higher mortality if you are using steroids early in your course inside the NICU. Later use of steroids may be beyond 7 to 14 days. It helps to decrease the severity of BPD, but in selected cases. So not that all babies who are being ventilated for a long time will require steroids, but in selected cases, yes, it helps to decrease the duration of respiratory support. So again, steroids have to be used with caution. So how steroids they cause the neuronal impairment is that they decrease the growth, increase the apoptosis, they will cause hypomyelination, and they will cause epigenetic changes in the brain. Then coming to the 10th intervention, which is my favorite, all the residents will agree, aggressive nutrition. So one thing which disturbs me in my rounds really is that the child is not gaining weight. Not my fault. I have been programmed that way. What happens, you see? So If a child is born premature, there will be insufficient energy intake. Then the child inside the NICU will have all these morbidities, that is RDS, IVH, infection, PDA, all these morbidities will have. All these, when taken together, they will lead to EUGR. This is problem is that over a period of time, if that EUGR is not corrected on time, it will lead to poor neurodevelopment, cardiovascular disease, decreased lung function, renal impairment, and even in the later stages, the child will be at risk for metabolic syndrome or insulin resistance. So just look at this. हमारे पास में day 1 पे आता है, हम लोग क्या करते हैं, 2 ml RT feeding रखते हैं, बाकी IV fluid. ठीक है, तो जो blue bar है, what blue bar you can see here, this is actually the nutritional requirement of the child versus the green bar जो नीचे है वो हम कितना दे रहे हैं. So हमारे साथ भी ऐसा ही होता है, पहले दिन पे हम फीडिंग कम देते हैं, ठीक है, एंड वी कीप द चाइल्ड ऑन IV फ्लूइड्स. सेकेंड डे पे हम 2 ml का 4 ml करते हैं, फिर 5 ml फीड करते हैं. तो होता क्या है कि बाय 10th और 12th डे हम लोग फुल फीडिंग पे आ जाते हैं. 10th 12th डे नहीं तो 6th 7th डे पे तो हम फुल फीड पे आ जाते हैं, एंड वी बिकम हैप्पी कि ठीक है हम लोग उसकी न्यूट्रिशनल रिक्वायरमेंट मैच कर रहे हैं. ठीक है, बट द प्रॉब्लम इज पहले दिन का डेफिसिट विल ऐड ऑन टू द सेकेंड डेज डेफिसिट, विल add on to the third day's deficit. It will keep on adding, and if you see on day 13 when you actually reach the full feeds, you have this much big deficit. Okay, so the red bars at the bottom, they are the nutritional deficit in the child. So that is why nutrition is one thing that has to be aggressive when you are dealing with a child in ICU. Okay, so if you look at the evidence, so all these babies who are having EUGR, that is extrauterine growth restriction inside the NICU, what it was associated with poor MDI, that is the mental developmental index was less than 85, and it was more so for the severity of EUGR. मतलब जहाँ पे आपके Z score is less than 2.5 standard deviations, your odds were little bit less, but if it is less than -3 standard deviations, your odds are higher. ठीक है, so and the relation is not affected by any gender or small for gestational age. ठीक है, so that means nutrition has to be aggressive irrespective of the gender and irrespective of the in utero growth status. Then you have to screen for preventable causes of neurodevelopment, poor neurodevelopment. It has to be treated aggressively. Okay, so all these three should be a big no. While you are treating a child in an ICU, there should not be any hypoglycemia related brain injury, no hyperbilirubinemia related brain injury, and no hypothyroidism. Okay, so there are n number of studies available which show that any of these will have a poor long-term outcome. Then I cannot stress the fact more. Okay, we can sit and have n number of fights, discussions, but 100 point thing is, until and unless you take care of the sepsis part, your neurodevelopmental outcomes are not going to be good. Okay, we can have n number of discussions, 36 hours duty, 44 hours duty, 36 days duty, whatever you do, you prevent sepsis and show me. So the day you prevent sepsis, I will be happy. Okay, so why? Because it has been proved beyond doubt in almost all the studies that once a child develops late onset sepsis or hospital acquired infection, your poor motor outcomes are the most prominent finding. Even hearing and vision impairment would be there. Okay, and so all of us know all these things that what has to be done. So just by ensuring the 5 movements of hand hygiene and just by practicing good hand hygiene, you can decrease your infection rates by 50%. Okay, unfortunately, that is the most difficult part, I feel, to ensure hand hygiene. Then coming to the second last intervention, that is developmentally supportive care and family centered care. I think ma'am has a talk on it, so I'll not go much into the detail, but does anyone know who she is? Who is this famous lady? No. Okay, so she is Dr. Hades Als, and she was the first person who brought this concept of family centered care and developmentally supportive care in NICU. And so these are the components of developmentally supportive care, that you have to provide a healing environment. So you have to provide a healing environment. You have to partner with the families. Okay, families should be allowed to enter the NICU. Positioning has to be proper. So if their nursing is not good, I become angry because this is important. You have to protect the skin, minimize pain and stress, optimize nutrition, and you have to safeguard sleep. Okay, and so this was a systematic review. as to how much developmentally supportive care will help. And it has been proved beyond doubt that here also, if you provide a good developmentally supportive care, the mental development index, it goes down by 45%, which means there is 45% chance that the neurological outcome would be better. Okay, both the mental development index as well as the psychomotor. So both are better. And coming to the last part, again, the point of conflict between me and my residents, अग्रेसिव पोस्ट डिस्चार्ज फॉलोअप एंड अर्ली इंटरवेंशन. ठीक है, वो फॉलोअप क्लिनिक जो सो कॉल्ड फॉलोअप क्लिनिक चलता है उसको इसीलिए अग्रेसिवली फॉलो करना है, बिकॉज a large chunk of these babies, they might be normal at the time you discharge them from the NICU, but there is a high chance they'll show some or the other problem in future. So you have to have a aggressive follow-up. ठीक है. Okay, and what this concept of early intervention relies on is the concept of neuroplasticity. That is, up to the age of 2 to 5 years, there is still a window of chance that if you pick up the children early and if you intervene at an early stage, you can prevent the long-term neurological morbidity to a greater extent. Okay. So that is why there have been multiple systematic reviews and meta-analysis. This one being the latest one from the Cochrane. Okay, and even this one also shows that early intervention programs for preterm infants have got a positive influence on the cognitive and motor outcomes with cognitive benefits even persisting into the preschool age. Okay, and this is precisely the very reason why the government of India also has brought up this program, that is district early intervention centers. Okay, तो ये जो DEIC का concept government of India लेके आई है, that is to identify these babies early and to act on them early so that you ensure that they have a long-term better outcome. Okay, so today is actually the opportunity to build what we want tomorrow. So if we want the next generation to be doctors, engineers, or professionals, the care has to start from you and me in the NICU today. Right? Thank you.